So for wrist and hand, it's really a good idea to put their hand on a table, or you could have them sit on a chair and then just rest their hand on the exam table, because it's really easy to look at things like how much they can move their fingers off the table, and that's how a lot of it's taught. We're just going to do it with her seated here. So the first thing I'm going to do is a visual inspection, so just hold both hands out here, and I'm just looking for discoloration in the hands, swelling, bruising. Look at their nails, do some cap refill testing. Don't forget to look for things, metabolic things like nail clubbing, not just orthopedic things. Check the skin. I always do a quick neurovascular check, so radial pulses, they're good and strong. I always go right into intrinsic and grip strength, so hold your hands out real wide. Don't let me squeeze your fingers. Good, hold your thumb up. Always do that, make sure they can hold their thumb up. That tests the integrity of the extensor pollicis longus tendon, which is right through here. So this is your snuff box right here. And this is your abductor pollicis brevis, and that's your extensor pollicis longus. So those two tendons make up the snuff box. And that's a really important landmark because your young athlete that had the Fuchs injury, if they have snuff box tenderness, that's a red flag. That patient needs to be, even if your x-rays are normal, that patient needs to be put in a thumb spica splint and referred to ortho, and they usually do an MRI. You don't want to miss that. That's a highly litigation problem, not just in urgent cares, but primary care. That's the kid that comes back 3 weeks later and their wrist still hurts. Now they have a non-union because you didn't immobilize them. So,
because that bone gets poor blood flow, right?
yes, that bone is, because of the way the blood flow comes in, it actually runs distal to proximal. So the proximal pole ones don't get a very good blood supply. And so if they fracture there and they're not immobilized, they usually end up with non-union. So the surgeons usually just go ahead and fire a screw in those if they're in that location. Wow. And a lot of times, even if they get them later, that the screw doesn't work and they end up doing bone grafting. It can be just a series of surgeries that you could just avoid with a simple thumb spica splint, refer to ortho, they cast them or they do the surgery. But don't miss it. And we're going to show some x-rays of it and go through it more. But so that's what I started talking about was the whole, can they lift their thumb off the table? That's EPL intact. That's how you document that. So we're just going to kind of palpate. So you're going to I always give the elbow a good squeeze, even though their wrist is swollen. He has a buckle fracture. I know it. I knew it before I walked in the room because I read, give everything a squeeze. So I'm going to squeeze her humerus. Does that bother you when I do that?
No.
Good. Can you move your elbow around? And that helps you decide, do I need to x-ray the elbow too? And I always start away from stuff that hurts because you don't want to just dive in on their wrist because then they're not going to trust you. Mm-hmm. And if I see a bunch of swelling in their wrist, I'm not going to dig in on their distal radius. I know they've injured it, so I'm not even really going to push that hard on that. Mm-hmm. But if they have a distal radius or ulnar fracture, and you just come up here on their forearm and just kind of go like that, that hurts. So you just squeeze their forearm, and then you kind of work away from the injury. You're palpating the fingers, checking range of motion, so you can make a fist for me. Good, open up real wide. And we're going to go into some of the provocative tests later with the fingers, but this is where I would usually go into range of motion. So just hold your hands like this, flex them down as far as they'll go. Good. Back as far as they'll go. Hold them like this and go side to side. So you just knocked out wrist flexion, extension, radial deviation, ulnar deviation. Radial deviation usually hurts with a scaphoid fracture. Ulnar deviation hurts a lot with that TFCC injury or distal ulna injury.
What does that stand for?
Triangular fibrocartilage complex, TFCC. So those are those chronic wrist pain patients where this is the ulnar styloid, you slide your thumb distal, and that's where that lives. So those patients, and that's like the meniscus in the knee, it just doesn't heal. So now I have them make a fist. I kind of do my wrist flexion extension manual motion testing with the fist. So bring your wrist down as far as you can.
You're in front of the camera.
Oh, you're right. Good. Hold them down really hard. Don't let me pull you up. Try to stop me. Good. Pull them back as far as they'll go. Hold them there. Good. And I like to do everything else sort of with the handshake method. So shake my hand and don't let me push your hand down. You try to stop me. So there's my radial deviation. Don't let me pull your hand up. There's my ulnar deviation. And then you can go ahead and just do pronation supination. So just flex the elbow. Try to rotate that way real hard. Push. Yeah. Go the other way. And then the handshake really works well to knock all those out. So we've done our snuff box tenderness, we've palpated the radius, we've palpated the metacarpals, we've checked our range of motion of the fingers and the wrist, so we've kind of knocked all that out. Provocative maneuvers for the wrist and hand, most of them are for carpal tunnel, but we'll go through those. So Finkelstein's test is for De Quervain's tenosynovitis. That's your 40-year-old daycare worker that picks up kids all day long. They get a lot of, even people that work cleaning houses. And Finkelstein's is basically, you gotta be careful with that test because everybody, and you guys can do this at home, just grab your thumbs like this, and then just ulnar deviate with holding on to your thumbs, just go slowly. And everybody in the room here and everybody at home is feeling that kind of pull. It doesn't feel good. It hurts in the first dorsal compartment. So if they have Dequervain's tenosynovitis,
Right here is where it hurts.
yeah, it hurts right through here. And she's got to hold her thumb and I'm cranking real hard, she's not gonna like me. But this test, you're basically deciding is one hurt more than the other. It's gonna hurt. But that's stretching those tendons that we talked about, the EPL and the APB. The muscles run right up through here. That's called the first dorsal compartment. And if those are swollen and tender, that's gonna hurt. That's a good test. Watson's test is for scapholunate instability. I'm gonna show a picture of scapholunate dissociation, but you see that x-ray where it's widened? You basically, if you turn the hand over and you palpate this little bump on the it'd be right at the proximal row of the carpals, that's a good landmark to use for the scaphoid. It's also a good landmark to use when you watch finger cascades, so kind of flex your fingers up. When you flex your fingers, go ahead and flex them up. The normal cascade of the fingers, they kind of go towards that same bump. So that's when we talk about cascade. You know, when you flex your pinky, it's not going over, I can't even get hers to do it, but it's not gonna go towards this, it's gonna go towards that.
Oh, right.
You know, so that's
Right.
normal cascade. But if you palpate that bump and move a little bit on to the ulnar side, and then you squeeze here, you're basically on the scapholunate joint. You're just kind of pull your thumb out for me. You're just sort of lateral to that EPL tendon. So let it relax. You'll feel like a little dent right there. Give that a good squeeze and now just have the patient move their hand around in a circle, or you can grab it and do that. With Watson's test, if they have scapholunate instability, you might feel a little click there, it might reproduce their pain. So you're just kind of palpating here. So that's Watson's. That's kind of a,
And that type of injury you immobilize and follow up?
yeah, I send that to upper extremity ortho. That's
Okay.
usually surgical. They have to kind of reduce those. And get
And
that.
the Dequervain's, that's just a
So
thumb spica?
Yeah, Dequervain's I put in a thumb spica, and if they don't do better with NSAIDs and rest and thumb spica, they usually inject that. Cortisone injection. So now we go into our carpal tunnel. So carpal tunnel syndrome, the tests are, that's your patient that's waking up at night, their fingers are tingling, thumb, index, and long. Median nerve compression test, so you're just squeezing, you know, the median nerve runs right through here. This is the transverse carpal ligament. When you do a carpal tunnel release, they make an incision right here and they cut that ligament right there. So that's where the nerve runs. So you just take your fingers and you squeeze right over that nerve and give it a good hard push and just hold that. And you can do them both. I'm gonna get in front of the camera, but you can kind of hold their hands like this and do them both at the same time. Because if they have pain on the right and they're like, okay, my right hand, my fingers are starting to tingle. It takes a little bit of time, usually like maybe 10 to 15 seconds. If you're holding that, then they'll start feeling the tingling. Same thing with Phelan's test. Everybody put your hands like this, yep. And you just kind of have them sit there and hold that for a little bit. And then as they hold it, they're gonna feel the fingers start to tingle after a period of time. So that's Phelan's. And I do all those on my carpal tunnel patients. I always do Phelan's, I always do median nerve compression. Tennell's test, don't get a lot of positive Tennell's, but Tennell was a neurosurgeon that sort of discovered how nerves regenerated and how, as they regenerate slowly, the nerve endings are very sensitive to tapping. So every time you do a Tennell's test, anywhere on the body, it's a tapping test. Same thing on the elbow, cubital tunnel.
Okay.
But you just kind of tap on that nerve, and as I'm doing that, if it shoots pain down to her fingers, that's a carpal tunnel. So you do it on both sides, just kind of tap. You gotta be pretty hard, pretty vigorous with it. Pinch test, just hold both hands like this. This is for more advanced carpal tunnel. I just have them hold that, and then just don't let me pull my fingers through.
Oh.
And if they start to get weakness in their thenar muscles, make sure you look at their hand too. Flip this over for me. See how Kim's is nice and bulky and strong? If that starts to show atrophy, that's usually carpal tunnel, and that means it's been there a long time. So if you see the atrophy and you do pinch test, they're probably gonna have some weakness in that thumb.
A trick I always use for thenar and hypothenar is thumb thenar, if that helps anyone.
Yeah.
Maybe people know that, but
Yep, that's good. Did you guys all see that? So hypothenar and thenar is what she's saying.
T,
Thumb.
thumb, but thenar, yeah.
Yep. And so now the last thing is the fractures, snuff box tenderness, so make sure you're giving that a good push in the snuff box and you kind of dig in there. And we talked about that already, thumb spica splint. And then finger scissoring, so finger scissoring is if there's a metacarpal fracture and it's rotated as you flex the fingers up, remember that normal cascade? Well, now as you're flexing up, let's say it looks like that. That would be scissoring, so. And it might be out too.
Well,
My-
since that fifth metacarpal is always broken so much, what will they look like? Kind of like they won't bend
Well,
it?
so a boxer's fracture?
Yeah.
If it's a boxer's fracture, most of the time with those, they lose extension because they're gonna be volar angulated.
Okay,
Because they hit something and it
Uh-huh.
pushes it volar,
okay.
so they lose extension. So
Okay.
you have, that's that table thing. You
So
put
they
your
won't
hand-
be able to cascade then?
Well, it
No,
depends.
no, extension, okay.
Yeah, they'll lose some extension. It depends on how bad it is. Sometimes they don't even wanna make a fist.
Right.
And, you know, it hurts, but, they always, if it's volar angulated, when you have them hyperextend, they're gonna lose that extension. So
Okay.
it'll look kinda like, like your hand should do that, well, they might look like that when they try to extend.
Okay.
So, all right, so we are gonna move on here to some x-rays.